Well, thank you to our speakers for a really wonderful esophageal function testing first session. I'm still like taking notes, and I'm glad this is recorded because I'm probably gonna have to go back and look back at all of that. A couple of questions that I think some of them were asked. I want to first make sure that we answer an audience question, and this is for Chris and Kit. Should one report on the landmark LES pressure in the upright patient if you're trying to do Chicago classification 4? You know, most of these motility studies are done, obviously, sort of supine. Do you guys do upright swallows as well?
We do upright swallows as well as supine swallows, and it's a tricky situation. And I think it's one that doesn't necessarily have an easy solution, but we do both because I think that it does give us valuable information to see if there's an abnormality present in one position that then resolves in the other. It makes us think that there's less likely an irreversible motor abnormality that then requires something as aggressive as a surgical intervention. I'm not sure, Kit, what you think.
Yeah, I agree. At the Brigham, we do both. At the VA, we do primarily upright. So I think upright swallows definitely contributes to disease diagnosis.
And I also had another question. I just got back from a SAGES consensus conference about GERD and pre-op testing. And one of the questions that still gets brought up is, what do you do with this ineffective esophageal motility? You know, you want to do a wrap, you keep telling us, or telling Charu, you got to get a motility study before you do the wrap. And then Charu gets the report and it says ineffective esophageal motility. And he said, what am I supposed to do with this? What do you guys think? Charu, are you good with that? Are you okay with the wrap?
No, we as a surgeon, you know, we always get trepidations when we see that report, obviously. And it would be great to get your opinion. But as a surgeon, we are always very careful about when we see ineffective esophageal motility.
So I will say, you know, with Chicago classification 4, the diagnosis of IEM is a little bit more specific. It requires more failed or weak swallows in order to meet that diagnosis. But I think this is where working together with your motility colleagues is really important, because there are times when patients will be diagnosed with IEM on manometry when really they're just, you know, 1 or 2 swallows away from having hypocontractile esophagus. So I would say, you know, this is where if there's any sort of question, you should talk to the motility doctors. I would be much more hesitant along with you if the patient were, say, having 80 to 90% failed swallows and just, you know, 1 peristaltic swallow. You know, that doesn't technically meet the diagnosis necessarily of hypocontractile esophagus, but you know, it could be early onset or sort of like early hypocontractility. So I think this is where, you know, getting into the nitty gritty of the actual report and talking to the motility provider will be very helpful.
So I think this is
absolutely agree. I think that's also the importance of the provocative testing that Dr. Chan mentioned. So if you see a diagnosis of ineffective esophageal motility, which is now thankfully a bit more specific. The prior iterations of ineffective esophageal motility diagnostic criteria could be met more easily in healthy controls that have no esophageal body dysfunction, but that's where the muscle rapid swallow, I think, has an important role. If you see ineffective esophageal motility, but you see that when you perform the provocative maneuver, you do have decent esophageal peristaltic reserve, then it may make you less fearful to pursue an anti-reflux surgery. Maybe considering a toupee or versus a Nissen, but that's where those different esophageal parameters come into play. And for those of you listening in the audience where you're not having, in centers you don't have these provocative testing being ordered, you should request that they get done or figure out a way in order to help ensure that your referral patterns are appropriately triaged.
David, I'm sorry, go ahead.
No, I just wanted to say that I completely agree that this is a topic of so much interest between the surgeons when we do these procedures, and nothing can replace a two-way dialogue with the motility specialist to really make sure that the patient will benefit from a partial wrap. And that's where the multidisciplinary teams come in play. And again, I completely agree with Dr. Velez and Dr. Lowe here. On that note, I actually do have one follow-up question, if that's okay, Kumar.
Yeah, go ahead.
Because the new Chicago classification has helped a little bit, but what is the opinion on this EGJ obstruction, diagnosis when the endoscopy really did not show any evidence of that? Or, for example, Dr. Rossman's barium study didn't show anything like that. And we get to this point where we're going to do anti-reflux surgery, and what are the options there?
I think one of it's always a challenging diagnosis. It's challenging before Chicago 4. I think it's still somewhat challenging because a lot of, the study have shown that a lot of these patients are diagnosed. A good portion of these patients, if you don't do anything, a year later, they're all better. So, you obviously want to make sure that you're not over-treating these patients. At the same time, is it a contraindication to things like anti-reflux surgery? I think that's when using the combination of the other studies with the time barium, specifically the time barium with a tablet, to look for obstructive pattern and the endo flip together will be useful. I kind of see them as sort of 3 different criteria. If you meet all 3, I think that's pretty convincing. If you have like one criteria, the two being normal, I think I'll be less excited to actually pursue any sort of barrier therapy. And then you have to sort of be more equivocal cases. We do, one thing that sometimes we do, I know it's not the favorite amount of a lot of surgeons, it comes down to temporary trial therapy, like, Botox injection or something, as a way to see if they feel better afterwards, symptom-wise, to see then should they get more definitive treatment. But I know that's I know that sometimes create fibrosis and other things that might be a trouble for surgeons. But it comes down to it. Rarely we might even consider that diagnostically.
Walter, you mentioned the timed barium study, and I wanted to bring Dr. Rossman into the conversation. I sometimes have a hard time getting outside radiologists to do a proper timed barium study. I mean, you guys are great here. I'm sure the Brigham radiologists, same, they do it. Is there, how should you be communicating with those radiologists? Is this something that most general community radiologists would be willing to do? Is it just a dialogue? What is the reason?
Yeah, I think it's a dialogue because it may be the case if they don't have a comprehensive esophagus service the way that we do, they just might not be very familiar with the study. But frankly, the other thing is that once you explain what you want, if they're not used to it, there may be a certain amount of discomfort with it because it really doesn't do a good mucosal evaluation, and we actually won't allow a timed barium swallow without a standing diagnosis of achalasia or some sort of motility disorder that we know, because there have been errors in which there is a cancer missed because what is pseudoachalasia not yet diagnosed can be problematic there. And so we need to make sure that just everybody's communicating of what is needed, what is shown, and what is not. And so long as it's made clear in your conversation, we are not looking for mucosal evaluation. We have a standing diagnosis. We are not concerned about mucosa. We are simply concerned about function in a time barium swallow. And then say, here's how we want it done. Most will be willing to do it because it's a very straightforward thing to perform. But you do want to get it right, and it's different from the way that we do most of our fluoro studies, keeping the patient in the same position. It's actually the opposite of what I normally teach my residents that they should be doing. So I think, like in medicine, almost everything is communication.
We have a question from the audience. I'm curious what everybody thinks here. If you have EGJ outflow obstruction confirmed with high resolution manometry, and then as Dr. Chan mentioned, you do an endo flip, it looks like it's pretty consistent. What's your next step here? What would you guys recommend?
I think the use of Botox injection is reasonable. I think the old teaching used to be, if you're thinking at some point down the line they're going to need a myotomy at some point, particularly POEM per oral endoscopic myotomy, that then you may have fibrosis that results from the injection of Botox, I think is less of a concern, although I may be incorrect in that. And a surgeon on the, if you could correct me, please do. And I think that would be what I would do first, because there's so many EGJ outflow obstruction. It may be an early stage of what will eventually become achalasia, but a certain significant percentage are also not going to have any abnormality and will resolve on their own. And you don't want to subject this person to the possible morbidity of a complication related to EGJ-directed therapy that may not be necessary.
One thing I want to add is that the most important part is what the symptoms are, and I usually classify the symptoms into more perceptive symptoms and obstructive symptoms. So if they're mainly coming in for pain or burning or symptoms like that, which are perceptive, I'll be less likely to pursue an EGJ targeted therapy, because their symptoms may not be directly related to the findings that you're seeing. But if they're saying that they have dysphagia, they're regurgitating food they're eating that's really sound obstructive, then I'll be more inclined to start with either a smaller dilation that maybe then progress to larger, or maybe even Botox and treatment like that. But I think having a clear idea of exactly what the complaints are, it's important, because you might not be treating the right thing.
Yeah, and also important to reiterate, it's very different, going along with what Walter just said. It's very different when you're finding these possible evidence of EGJ outflow obstruction if you're doing manometry as, say, part of a reflex evaluation, as opposed to someone who's actually having dysphagia, and that's why you're treating. So again, going back to the clinical indication, why you're doing the test in the first place, and whether or not you actually think that finding is contributing to the patient's symptoms is most important.
I think it highlights that these testings are all great, but they're complementary. None of them in isolation is going to help you with this patient with EGJ outflow. And I think, as Dr. Velez mentioned, they may just stay where they're at, or they may eventually evolve. I think, in my opinion, if I have somebody with the right symptoms, with low DI, with EGJ outflow obstruction, dysphagia, I probably would get a time study. And if it was delayed, probably would offer a POEM. I don't know, Charu, what do you think?
I was just going to say that I think, if the symptoms correlate, I think it's more beneficial for the patient to have a myotomy, either endoscopic or minimally invasive. And again, Dr. Velez mentioned that Botox, when it's injected, and then the patient comes for a myotomy, it's always difficult, I'm sure, endoscopically as well, but even laparoscopically or robotically also, because the amount and degree of inflammation in that space is tremendous. But I agree. I think if the symptoms correlate, and in this situation, I think it's very reasonable to offer them POEM or a surgical myotomy.
And I think part of what is, so at Mass General, for example, we have weekly multidisciplinary meetings between gastroenterologists and surgeons, as well as monthly meetings where we have a group of 15, 20 people meeting for more complicated cases. I think what's important is, as Dr. Krishnan just mentioned, is not interpreting a test and pursuing an intervention on one test alone. It's describing the symptom characteristics. Chicago classification is great, but when we look at, for example, when Dr. Chan was mentioning integrated relaxation pressure, software dependent, so that may be a source of miscommunication. And in Medtronic, 15 is the cutoff. Is 14.9 normal and 15.1 abnormal? Probably not. So there's a lot of, it's not enough to be able to deploy the test. You need to know how to also manage the gray areas.
Wonderful. Well, there's so many more questions left, and we'll have to save it for mid-2022. But thank you all, panelists, speakers, for being here, for giving us your talks and your pearls of wisdom. And we will very soon have some challenging cases coming up. So we will be right back.